Thank you, Sally, for getting the band back together. I am really excited to be able to be the opening act today, followed by Bon Jovi and Janis Joplin next. But to get started, do I have to click on something? I obviously didn't listen to NPR this morning and listen to the radio, so I have rock concerts in my brain. Okay, great, thank you. So I get to basically give you guys an overview today. We're kind of taking a different turn from what we had yesterday, where we talked about the therapeutics and how the outcomes really relate to the therapeutics. What I'm going to give you today is looking at the history and the development of these outcome measures. And so I think today's really exciting because all the big hitters that you're going to see here who helped develop and validate these scales will get to be your teachers in the afternoon. And so you really kind of get, I wasn't really kidding whenever I'm talking about the rock stars of SMA outcomes later on this afternoon. So to get started, here are my disclosures. I do have some advisory boards and consulting contracts with some of the industry partners that are involved in SMA trials. And so, of course, we always need to know where we're going to go. So in the next 45 minutes, what you'll hear from me is you'll get an overview of the psychometric properties and the assessments that are used in SMA in research, as well as what can be used in clinic to monitor disease and the disease progression, treatment, and treatment goals. And we're going to do this in a way to give you some kind of roadmap. And so as rehab professionals, we know what the International Classification Functional Scale is. So it's going to be based on the ICF model. And how can we use the ICF model, looking at that to make clinical decisions for appropriate disease monitoring and goal setting. Then on top of it, we'll look at understanding the appropriate functional clinical assessments that are used in the functional baseline assessments that were set by Dr. Parsons and Tessie Rocha yesterday when they described SMA. Instead of describing it by type, what we found is when you're looking at clinical outcome measures, it's much more useful to determine what's the appropriate measure by determining what the baseline functional status is. So in the changing landscape of SMA, where do we go from here? So I was inspired by A Whole New World, and so that song is singing in my head, but you don't get the privilege of hearing my terrible voice. So what do we do now? And so in this changing landscape, there's going to be changes in the outcomes that we've traditionally used. So that being said, this is what I think most of us feel like when we're choosing an outcome measure. So hopefully by the end of the day, you'll feel a little more comfortable in kind of your clinical decision making to fit these outcomes, to best fit the situation for your patients, to give them the best care and provide the therapy that they need. So that being said, I always talk about outcomes in the spectrum of research because what you've seen so far with SMA therapeutics is that the outcomes used in these clinical trials will end up being the outcomes that may be required of you via insurance or whatever reason to use in clinic. And on top of it, because it was validated outside clinical trials in a natural history study, there's a lot of good psychometric soundness to these scales. So the FDA has guidelines for validation of these scales. And there's 4 different outcomes, but really we're going to focus on the performance measure today, but I'll also highlight a little bit of the patient-reported outcomes that are used. And patient-reported outcomes are 2 different types. So there's the quality of life measures that everyone's aware of, but as therapists, we really typically look at performance or patient-reported outcome measures also by a patient's perception of how they're able to perform a function. So there are a few scales out there that you could tap into, but all the scales that we'll learn about today are really performance-based. So performance-based scales are observed or actual demonstration of functional performance in a clinical setting. Okay, so in consideration of these scales, we always have to consider what is the mechanism of action of the therapeutic agent. And so I won't go into that a little bit further because you had all of yesterday to talk about the mechanism of action and what outcomes have been shown to be effective. Then, of course, you have to look at the stage of the disease. And what we mean by that is looking at the functional level. Are they non-sitters? Are they sitters? Are they walkers? And how do these scales best fit in those for those patients with those functional levels? And then, of course, are the scales really validated for infants adults, or pediatrics. And so having that in mind gives you a scale that is more succinct, that's meant for the certain patient population that you're assessing. And then, of course, with all outcome tools, we want to make sure that it has good psychometric soundness, that is reliable, valid, and sensitive to change. And of course, we'll look at this in the scale of the ICF model. So most of what I'll present to you is this 30,000-foot view of a gigantic outcomes toolbox that you can use and pull the appropriate tools that you need to get the job done. And then this afternoon, my colleagues will go into detail of the outcomes that have been really validated and used in clinical trials so that you feel comfortable utilizing and administering it at home. Okay? So we can't talk about evaluations and assessments without variability. You heard yesterday from Connie and many of the other physicians about how the variability in timing of when the patients come in, and then you heard from the patient panel that when they get closer to the time when they need their treatment, they feel different. They can tell, they feel more tired. And so that happens. And so you know there's already innate variability that exists in the clinical setting. In the clinical trial setting, we can control that a little bit, but we recognize that outside of the clinical trial setting, there's less control, and so how do you manage the chaos outside in a standardized way? We know that increased variability leads to decreased sensitivity of these outcome measures. And so you guys are taking the first step by coming here and learning how to utilize the outcome measures in a standardized way with the intent of the assessments itself to ensure that the administration and the equipment that's used was what was used in the clinical trials. Okay? And then on top of it, I know in real life you can't always have the same therapist treating the same patients, doing the same evaluations for the entire treatment period of the patients. But keep that in mind as you're following these patients, that we know that intra-rater reliability, the same person doing the same evaluations, are much more reliable than inter-rater. And so as objective and quantifiable as some of these tests are, there's still some room for clinical judgment, as you'll see in some of these scales this afternoon. So that being said, I really want to emphasize CureSMA has this clinical trial readiness toolkit. Sally will talk to you about it a little bit later this afternoon, but this toolkit is a great resource. And don't get scared that it says clinical trial readiness. It's not necessarily only for those who are thinking about doing clinical trials. It has a lot of tools that really help you as clinicians on deciding about outcomes, where to get resources. And so one of the resources is this figure here. It's the ICF model based on a whole bunch of clinical outcomes that could be used. And so what I love about it, because it's exactly how I was taught to think as a rehab professional. First, you look at the body structure and function, what assessments fall under that body structure. You can't really see this. Body structure and function. And so a lot of that is strength, range of motion, pain, fatigue, respiratory. How does that organ-specific structure or function play into a patient's ability to do things and activities? And so today we're going to focus on that primary middle category of function. And so you see the CHOP and 10, the HINE, the WHO, all of these outcome measures you've heard frequently that's used as an efficacy measure in these clinical trials. And then, of course, we go into participation because we want to know if they're able to do this. Is it changing their quality of life? Is it helping them participate better in school, in work? And so then you have the participation category, which is mostly consistent of the patient-reported outcomes that I talked about earlier. So I'll just touch base on a few of those. And then beyond, this is just all we'll talk about from the impairment-based level. Beyond function, as therapists, we need to look at strength. And so how do we look at strength to give us a clinical picture of what's going on with the patients? How we learned about SMA and the progression of SMA and how we diagnose in neuromuscular is really looking at the pattern of involvement of muscle weakness and the imbalances around a joint. So what we know in SMA is that one, it's a proximal to distal weakness disease, and lower extremities are more affected than upper extremities. And as you heard from the patient panel, most of the patients report with the disease modifying treatment, they're getting more gains in the upper extremity before the lower extremities. So these are the things that you keep in mind whenever you're doing the assessment. And so then, of course, there's overuse weakness. That's always the biggest question with the most difficult answer. Unlike other muscular dystrophies, SMA, you can do resistance training, you can do strengthening, and Jackie and Richard will talk to you a little bit more about the details of that specific type of intervention. But keep in mind that you can always do strengthening, but keep in mind that overuse weakness is a factor, and you want to make sure that the patients are strengthening within their available range. And then, of course, with progression, how with the new treatments, how is that changing the muscle imbalances around a joint, and how may that affect function? And so I want to just quickly talk about the pattern of weakness that we see, or involvement of muscles around a joint in SMA. So at the hips, we know that the hip flexors are more involved than the hip extensors. So when you do basic MRC testing, you'll notice that pretty readily. And then when you're looking at triceps and biceps, the triceps will be much weaker than the biceps. And then you go down to the lower extremities, quads are quite a bit weaker than the hamstrings. And so when you look at gait assessments and walking assessments, Jackie has done a ton on understanding what muscles are activated during walking. You heard Dr. Parsons talk about a stiff gait pattern when the kids are walking. Hamstring seems to be a very important muscle in walking for patients with Duchenne. I mean, not Duchenne, with SMA. So what I was saying that we always think about quads. We see a lot of patients who have no quads, but they're able to walk. And so the hamstrings actually is pretty powerful muscle that, I think maybe have been a little bit underestimated. And Duchenne is another field that more recently a study was published by the Institute of Myology saying the same thing, that the hamstrings are very important in walking as well. So keep that in mind as you're thinking about your strengthening program specific for function for these patients. So then I want to give you a general outlook of how I approach strengthening. So we always talk about the quote unquote subjectivity of manual muscle testing, but we all do it because it gives us a good clinical picture of what's going on. So you have a scale of 0 to 5, 0 having, very basically no muscle contraction, 1, you can feel the palpation, and then 2, a gravity eliminated position. And so if you look up here at the very top diagram, you can see 0, 1, 2, and 3 encompasses maybe 10% of this scale. So that scale up here is handheld myometry, right? And so this is where most of the MRC scale kind of centers. But then you look at 80% of it is under a 4. So that is where the quote-unquote subjectivity of the MRC grade comes from. What is my minimum? What is your minimum? What's my max compared to your max? And so in order to do that, in the 3- to 3 range, what I typically do is measure active range of motion. It doesn't need to necessarily be with a goniometer. It could be eyeballing, but it's functionally relevant. So if a patient's able to move their shoulder 30 degrees, but then tomorrow they're able to lift it to 90, there's a lot of function that happens in that mid space that could be related to their active range of motion. And that is a method to also measure strength. Then you get up to the 4- to 5. So then that's where the resistance, they have full range of motion, and how do you measure the amount of strength they have? And that's where you introduce some of the handheld myometry. So that kind of gives you a little bit more granularity in manual muscle testing and handheld myometry to make it more functionally relevant. Okay. So now we'll get to the meat of the matter, and that is functional testing. It has been used to monitor the natural history and disease progression of SMA, obviously used as efficacy measures in therapeutic trials. And what we know is that because it's a multi-organ disease, one single test is not going to be the test that's able to track the entire lifespan of these patients, right? And so there has to be, looking at the ICF model, understanding their functional level and their age, what outcomes are appropriate that you should pick. So that being said, there's norm reference and disease-specific assessments out there. Norm reference are great because it gives us an idea of how they compare to the average population. Especially with the disease-modifying therapies, it's nice to know how quote-unquote normal they may be functioning. And then particularly for infants, it's hard because now with infants, they're developing, they're gaining all these gross motor skills. How can you differentiate that from actual basic development, as Isaac's father said, or is it actual treatment? So then that's where you have the tests that you're very familiar with, Bayley's, Peabody, developmental scales that have been normed to a larger control population. And of course, being norm reference, you know, that's a little less sensitive than more disease-specific tests. And so the disease-specific assessments have been based on the knowledge of SMA disease progression as well as the phenotype. And so there will be less floor effects because it's very disease-specific, and it's more likely to be sensitive to change. That's why these are usually the efficacy measures that are used in clinical trials. So what's highlighted in red, based on the functional groups, are what's going to be covered today. And so here we go. Beyond the ICF model, we have function-based assessments. And where do these assessments fall under the functional categories? So here we have non-sitters on the far left. And in the non-sitter category, some of the outcomes that could be used is the CHOP-INTEND or the CHOP-ATEND. And that's in current development right now with the PNCR and ISMAC groups, because we need something for adults who are not able to move very much. But how can we don't have a really good measure that's sensitive enough to look at some of their basic mobility in their chair or in bed? And of course, the TIMSE is based, the CHOP-INTEND is based on the backbone of the TIMSE. And then you see the sitter and the walker category. The primary assessments that you've heard about under this category is the HAMMERSMITH expanded, the RULM or the ROLM, and the motor function measure. So today you'll learn about those two. I'll touch base on the MFM. I added a couple slides so that you can have a better understanding what those differences are, knowing that the risdiplam fish studies have the MFM as a primary endpoint and how that may impact what you may be required of you to do to assess patients with SMA. And then of course in the walker category, you have the 6-minute walk test and some of the time function tests that Jackie will talk more about the 6-minute walk test a little bit later. And then, of course, we can't forget the pre-symptomatic babies that are being treated. And with the pre-symptomatic babies, of course, do what you know. The basic Peabody, the Baileys have been frequently used now to assess those babies compared to the development trajectory of normal babies. Okay. So I just wanted to talk a little bit about how these outcomes came about and why they ended up being decided as clinical efficacy measures in trials. So in 2014, a lot of experts, including those who are at this meeting, got together and said, you know, what scales are suitable to measure SMA? And so that's part of clinical trial readiness. So they looked at all these outcome measures, including the ones that I talked about earlier, but they also looked at what makes a good functional outcome measure. And part of it is having a natural history. We need to understand how the scale's responding with patients with SMA to really see how, if there is a change, that we believe it's a real change. And then it has to be reliable. It has to have good discriminant construct validity, have good clinical meaningfulness, and be able to be implemented in large multi-site clinical trials and have clinical utility. And so that being said, you could see that in 2008, not much work was done on these measures. Then you move down to 2016, and the work that was done to validate these scales were skyrocketed in both the MFM, the HAMMERSMITH, the ROLM, and the 6-minute walk test. Okay, so then now we're going to just briefly talk about the infant measures, and I'm going to give you an idea about the WHO, the HINE, and the CHOP-INTEND. So the WHO you heard discussed, and many of you probably know what it is. There are 6 gross motor milestones that have an age window of achievement. And basically what this does is it operationally defines major motor milestones, including sitting, standing with assistance, walking with assistance, also walking alone. And so it's meant for patients from the first to 18 months of age. It's clinically meaningful, and except for it's not so granular. And so then you have the HINE. And the HINE has 3 sections, but we're going to focus on the developmental milestone section. And it's a neurological exam that's in the trials, typically done by the neurologist, but in some places it's absolutely appropriate too to have it done by physical occupational therapists. It's meant for 2 to 24 months of age. It is norm reference, and it's a little bit more granular than the WHO is. Then I'm not going to go into further detail here because you've heard the HINE being used in clinical trials, and it is able to determine change and attainment of motor milestones, as you can see here. But it also was shown to be have really good, excellent reliability. So now we'll go to the CHOP and 10. So the CHOP and 10 is different. It is an SMA-specific scale that was designed for patients who have SMA1, who are really low tone and very, very weak. Okay, it has both active and elicited reflexes. Alan and Leslie will talk to you a little bit more about it, so I won't go into details about it. But besides that, it has good reliability. We have used it in multi-site trials, global trials, and has good validity. I know that Dr. Finkel showed this slide, but I want to point out here for those of you who are looking at it from kind of a lifespan perspective. If you're choosing clinical outcomes, you see the NeuroNext study. It looks at patients who did not have SMA on the right, and then patients who did have SMA on the left. You can see that those patients who do not have SMA really top out at the score of the CHOP and 10 around 3 to 4 months. And so all the items that are part of the CHOP and 10, these babies obtain the high score pretty early on. And so then what do you consider if you're seeing a baby? That's whenever you may put in the Bailey or the Peabody as part of your assessment tool. And then lastly, we'll go into pediatric and adult functional measures. And so that encompasses the Hammersmith, the revised Hammersmith, MFM, Rome, 6-minute walk test, and some of the time function tests. Okay? I can't talk about the Hammersmith without talking to you about the history. So if you go to PubMed and you look up the Hammersmith, you really have to know that there are multiple Hammersmiths. So it's not just the HFMSE, there's the HFMS, which started in 2003 in the UK by Marion Main, which was a clinical assessment meant to monitor disease for patients with SMA2. So there was 20 items there that was arranged in a hierarchical manner, but then in 2006, it was modified by Kristen Crochel's group in Chicago to decrease the fatigue and reorder and clarify some of the items. And then we get to 2007 edition, that's the Hammersmith Expanded that you'll learn about today. And it was developed in response to the need to assess stronger non-ambulatory patients and ambulatory patients to kind of increase that ceiling a little bit. And so to do that, they added 13 items from the GMFM. So many of you may be familiar with the GMFM. So when you're going through the Hammersmith items, you're like, I remember that from my assessment for patients with cerebral palsy, Down syndrome. It's because some of these items came from the GMFM. And then, of note, it has been updated with the 2019 manual. So if you look for the Hammersmith, the 2019 manual has the most updated manual that gives you more detail about how to score and the administration. But the original intent of the scoring and the test did not change. We've learned a lot from teaching the Hammersmith with clinical trials. And so all of our learnings, we've tried to put it into a manual to where you can actually use to standardize your administration of the Hammersmith. In parallel to some of this work, we did rash analysis, so modern psychometric testing of the Hammersmith, and came up with the revised Hammersmith, so the RHS. So the RHS was designed to increase the ceiling of some of these higher task items, and as well as increase the floor effect of it. And so we have items added from the Hammersmith, the North Star, if some of you are familiar, and the CHOP and 10. So that being said, the Hammersmith is a hierarchical scale that you'll get more details later on. And the principle of scoring, the reason why I want to highlight this, because it is different from the MFM. There's a 3-point scoring system, 0, 1, and 2, with a total score. And so that's going to play a factor in when you're looking at interpretation of point change between the Hammersmith and the MFM. The Hammersmith is very reliable, has been used in large global studies, and it also is discriminate between SMA types, walkers and non-walkers, and respiratory function, as well as having really good correlation with SMN2 copy number. Okay, we saw here that it is a good measure to use to look at efficacy and change. So a 3-point change at 3 months, a 6-point change at around 9 months. And so it's been effectively used for clinical trials. And now we go to the RHS, which is based on the Hammersmith, and it is meant to assess patients with SMA 2 and 3. It's the things I want to point out here that's different is that the North Star items, we all know that some of the time function tests, that's part of the North Star, is integrated into the RHS. So you'll have those as part of the RHS. And then on the more floor effect, we added one hip abduction item from the CHOP-IN 10, and 2 of the WHO motor milestones were added, including cruising and walking, into the RHS scale. And the grading for the RHS is similar to the Hammersmith with a 3-point scale. Okay. Again, we have done good reliability. It's shown to be reliable. It's discriminate between SMA types, ambulatory status, and motor milestones. And then, of course, now we go from gross motor function to upper limb function. And so the revised upper limb measure was developed to look at upper limb functional performance, taking into consideration muscle strength, maturation, contractures, and postural constraints that are associated with patients with SMA. Its intended populations ambulatory to non-ambulatory, and has 19 items. And again, as you can see, the scoring is similar, a 0, 1, 2 scale. And there is a kit that's associated with it. Because it's a functional scale, a lot of the items in the kit is meant to be more like everyday items. And so you'll see there's a Ziploc container, cups, and things like that to mimic everyday items. The ROM was developed there's a ROM, ULM, that was developed. Then the revised upper limb was developed to increase the ceiling with some of the upper shoulder measurements. And so what we found is that the ROM is a really nice complement to the Hammersmith on the kind of the lower distal items. And so what you typically see is the Hammersmith being done together with the RULM. So you have some distal hand function as well as gross motor function that you're assessing at the same time. Okay, so all of that brings us to the MFM, the least known tool in the US, because it was developed in France by the Institute of Myology. And so this scale, if you think about the Hammersmith and you think about the RULM, this scale is trying to get all of it together. And what I want to make a really big point is that this scale is not SMA specific, but it's not norm, but it's neuromuscular disease specific. So it was made to assess patients with neuromuscular disease. And so they have 3 dimensions in it. D1 is looking at standing and transfers. D2, which is looking at kind of the axial trunk pelvic stabilization. And D3 is looking at the distal items. And with the distal items for the MFM, they really focus on some fine motor and writing skills. And so that's why you see there's the MFM 32 and the MFM 20. The MFM 20 was meant for the younger age group and validated for the ages 2 to 7, because particularly the fine motor items are not developmentally appropriate for some of the younger kids. So the subset of the MFM 20 is part of the MFM 32. Can they be directly compared? Not right now. The group who developed the MFM is currently working on something to make them comparable, but right now I would highly recommend doing the MFM 32, because at least that's a scale you can follow longitudinally. And of course, it also has specific equipment, but the thing with the MFM is they do have a website with videos and training, but you do have to submit reliability, in which it goes to the people up in France. They'll score it to make sure that you are reliable before they consider you a certified person who can perform the MFM. So that may be a tool that could be used once we look and see if the risdiplam is approved for patients, because the MFM is their primary efficacy measure. And so here, what I really want to point out is that we talked about a scoring system of 0, 1, 2. The MFM is a little bit more difficult because it has a 0, 1, 2, 3 rating, and you're not only looking at one aspect of function, you could be looking at range of motion, you could be looking at quality or compensation, and all of that can be combined in some of these items. And keep in mind, this is a neuromuscular disease specific and not SMA specific test, so a little bit different, but when you're looking at comparison, I think there was a question, can you compare the MFM to the HAMMERSMITH? If there's a 3-point change in the HAMMERSMITH, is that comparable to a 3-point change in the MFM? The question is no. There's just no way to really relate the two together. However, Elena Mazzoni did publish a paper that said there was high correlation with the MFM and the HAMMERSMITH, not expanded, the original HAMMERSMITH. Okay, and what they found was that the MFM really was able to provide more sensitivity in kind of the distal dimension, but the HAMMERSMITH was able to provide more sensitivity in kind of the trunk and gross motor mobility areas. Okay, so there has been studies to look at responsiveness of this scale itself, and it shows that with the MFM there is a gradual decline in motor function. And it also looked at SMA 2 and 3, and what they found is for in the D2 dimension that there was at least a 3-point change in 12 months for patients with SMA 2. And the greatest change for patients with SMA 3 or the ambulatory population was in the D1 dimension. So that's the standing and walking dimension, and there was a change of about 6 points there. Okay. So now we'll talk about the ambulatory assessments, and I'll be brief because you'll have details on that. So the 6-minute walk test, a 25-meter walk test that has been really well done and validated by Jackie Montes, and she'll go through that in more detail. But for those of you who have done the 6-minute walk test, you're used to having a total meter score. What has been really significant and the only true indicator of fatigue in SMA has been the 6-minute walk test looking at the per minute increments. And so what we've shown with the 6-minute walk test, Sally and the group in Columbia has shown that it has been really reliable to be used in patients with SMA. Jackie has shown in multiple studies that it accurately and captures fatigue really well. There's demonstrated 17% decrease from the first minute to the last minute. And then in the longitudinal experience, Elena published that there is a mean change of 1.5 per year. But the thing I really wanted to emphasize here that was interesting is when you're looking at your patients in when they're in the pubescent period of life, we know that those changes really affect function. What they found was there was up to 30 meters of change for those patients who were still ambulatory in that period of life. So that's something to really be sensitive of whenever you have patients in that age period who are still walking. And then time function test has been less studied in SMA, but a study by Merlini in 2004 did look at the time function test and find good correlation between those time function tests and leg strength. And then, of course, the timed up and go, we're still looking to validate that a little bit more. Most of you know the timed up and go from Shumway Cook's geriatric studies showing that it's a really good assessment to predict balance. But it also has been validated in SMA by Sally and the Columbia group. Okay. Lastly, patient-reported outcome measures. So this is going to be brief. The PDCAT, many of you know, it is a caregiver-reported outcome that Amy Pasternak has done a lot of work with for SMA, and we're using it and it's validating in SMA. But it is meant to be a patient-reported outcome measure for patients 1 to 21. Has 4 domains looking at daily activities, mobility, social and cognitive and responsibilities. And so it's had some rash analysis done, and what they found is there needs to be more items to identify some of the weaker patients, but overall it is a good patient-reported outcome measure that may be used for patients with SMA. The SMA FRS has been used and typically used in adults. If any of you work in the ALS field, you're very familiar with the ALS FRS. This is a rendition of the ALS FRS. Keep in mind that there's a modified version that Ohio has put out. It's not the original version. So keep in mind that there's 2 versions, and a lot of us who are working in the adult space are using or looking at the SMA FRS and its responsiveness as a patient-reported outcome for adults. And then, based on some of the disease modifying treatments and the patient reports that we've heard from our patients, we notice there's some gaps in our knowledge and how to measure certain things. And so I wanted just to talk to you a little bit about some of the exploratory patient-reported outcome measures that we're starting to look at. And a lot of the improvements we're seeing is in the bulbar function, voice production, and so the last 3 assessments is what I'll describe there. The first one is the Egan classification scale. Those of you who work in Duchenne know that this is a well-validated scale for boys who have Duchenne who are non-ambulatory. It came out of the Denmark group, but what we found is that implementing this in our clinic for our patients with neuromuscular disease has been really helpful. It has 17 questions, 2 being observation, and 15 asking questions on how they're able to move outside their base of support, how they're able to use their wheelchair, and as you can see here, turn in bed, and a lot of it's respiratory health, how do they feel, are they tired, and then eating as well as fine motor skills. So it's a really good scale that you can use beyond SMA that we found so far to be anecdotally pretty helpful. And then because our patients report that they have improvements in their voice, we look at the voice handicap index. And what this looks at, I really like, is that there's 3 categories of function: physical, functional, and emotional. So we do now also give this to our patients to see if there's changes in their voice. And then lastly is the EAT 10. Connie stated to you that our patients talk about how food matters. And then Angie yesterday talked about food because and how important food is, because we use food, for good or bad, as a social means. We all go out, the first thing you say when you're, hey, let's go meet for lunch, let's go meet for dinner. This is really impactful when a patient can eat out with their friends. And so we looked at the EAT 10. It's a self-administered test, and it looks at, a 0 to 4 scoring with patients. And so these are some of the things we're looking to validate because our patients are reporting those kinds of changes. So in summary, you can see that the scales that we talked about here, the CHOP and 10, HINE, HAMMERSMITH, looking at the suitability of these outcomes, they all have been really well studied, and you can be comfortable in the soundness of them as an instrument. And so moving forward, this is the reason why we chose to use them in studies as well as present them here today for you to use in clinic. So I'll end today with really, as the theme is, in the change of this new natural history, we ended up having more questions than we have answers, right? And so looking at the assessments, we can tell you, we would love the HAMMERSMITH is the best test to use for assessments of patients with SMA 2 and 3. But the fact of the matter is, when a drug is approved and the FDA, for example, gives a broad label approval, such as with NUSINERSEN, and you can be treated if you're an infant or an adult, what really becomes the access barrier or gatekeeper then is no longer the FDA, but it has now transferred to the insurance companies, right? And so the insurance company, as Connie kind of talked to you about yesterday, was that they tell you what outcome measures they would like to see. And so a part of that is education to the insurance companies, but this is what we have. And so thinking ahead, knowing that that may be the case, the MFM is something that is not being taught today, but just keep that in the back of your mind. That's something that you may need to take a look at. And then how do these outcomes change in the changing phenotype? How do you need to adjust? Are the current outcomes that we talk about today sufficient, or do you have other outcomes and tools that you could use, or you could let us know that has worked for you in patients that are changing similar to the SMA phenotype? Because what we do know is that these drug-modifying treatments are showing some kind of effect, but anecdotally, what we really know is that these drug-modifying treatments need to be done in combination with physical therapy and exercise. And what we want to do today is make sure that you have some tools within your toolbox to be able to make the appropriate goals, modify the appropriate goals, so that your patients can get the physical therapy that they need. So that you don't have parents sitting up here and saying, I want my child to get physical therapy, the goals are not set right, and so I can only get therapy once every month. because we see that those patients who get both physical therapy and exercise in combination with treatment has been quite effective. So that's why we're here today. So that being said, a special thanks to local community, international community. As you can see, this takes a village, and I'm really appreciative to be a part of this village. And more importantly, my village here at Stanford, they are the backbone for us to be able to do what we do at Stanford. And so I thank them. And then most importantly, you guys, you now are part of our community. And for us to move forward and learn about this changing phenotype, we do depend on you to give us feedback back and forth. So thank you so much, and I will end there.
Thank you so much, Tina. We actually do have quite a few questions that came in.
Oh. I thought I was off the hook.
I'm going to start with some easy ones first, though. From which age is validated for the ROAM?
The ROAM, it really could be used toddler all the way up to adult. And so as long as they can follow one-step instructions, we've used it down to
30 months.
3, yeah, 30 months. Yeah. See.
Does the RHS have good natural history data available?
We are working on the natural history data. So our colleagues over here, as well as our groups in London, we have worked and collected as part of the PNCR network. So her name escapes me. Danielle Ramsey has published on some of the natural history, if you want to look her up for the RHS. And now we're looking at it from a longitudinal perspective as well.
And then speaking to the RHS, what are the advantages of using the RHS over the expanded Hammersmith in the ambulatory group?
Right. Feel free for any of my friends to pop in. But the RHS, we typically like to use it for the higher functioning ambulatory patients because we can look at the time function measures. And so in the Hammersmith expanded, they have walking and jumping, but they don't have some of the higher task items. And so that's what we like to use it for. But we also has been helpful looking at some of the changes in our patients with the pelvic girdle strength. And so their ability to bring their legs back in with the addition of the chop and tend item, that has been helpful too for some of our kind of lower functioning patients.
Great.
You guys have anything to add, please?
Well, anything to add? This last question I'm going to address to both you and Dr. Meyer. Are there objective measures that can be used across all age and functional groups, maybe some sort of PFTs? Are there reliable PFTs for infants that can be tracked into children and adults, and do PFTs parallel other motor function assessments? And we do have our microphone box now that we're going to do catch.
Do you want to start?
I mean, I think Hank would be the expert in this. I mean, I would be afraid to even to speak on the respiratory topic. So Hank, take it away.
So there are infant pulmonary function tests that are used for patients with obstructive lung disease that really have no utility in patients with neuromuscular disease. In terms of something that can be done across the spectrum, the only thing really is an end-stage outcome, which is polysomnography and hypercapnia. There are some experimental techniques for looking at mechanics, and Dr. Finkel and I, when he was at CHOP, did some work using respiratory inductive plethysmography, which has been used as an outcome in some studies. While there are some normative data, it's not particularly robust. And so I think the simple answer is, in terms of following progression, there really isn't a useful outcome measurement that can be used across all ages yet.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.